So good morning to all of you who just joined us. Welcome to today's session. We are going to be talking about care navigation and signposting for admin and reception staff. And we're really focusing mainly for staff working in Northeast London. My name is Jeshni Amblem-Alma. I'm a nurse practitioner and the course director at Belmat Healthcare Training. So we're going to go, I had a little chat to you all, so I had a bit of a feel of what you'll have in terms of services, and we're going to talk a bit more about it. So what we will do is the session, we're going to look at what is care navigation and, look at really how does it improve the patient access and experience. We want to keep patients safe. We also want to work safely. We want to send people to the right places so that actually in our duty in service providers, that one, we keep patients safe, we care for our colleagues where we work, and we are aware of what is available out there for patients, okay, and service users. We're going to go through some of the services that we can signpost patients. Not everybody needs to be seen by a doctor in the surgery. Healthcare has evolved that we can actually use lots of other services. Very importantly is about identifying when to escalate. What are those points where you think, I can't send them to a pharmacy, I can't just send them off somewhere, I need to actually someone needs to see this patient. It's in their best interest to be seen today. So when to escalate, making decisions, and so looking at some of the barriers that we face in terms of very vulnerable patients. How can we make access very inclusive so that we're being fair and equal and just to everybody? So care navigation ensures that patients are assessed and allocated to the right service at the right time by the right professional. So what can happen, do you all think, when care navigation goes wrong? What happens if we don't navigate a patient or signpost them correctly? You can put it in the chat or you can unmute yourselves. Any thoughts, anyone? Okay.
They won't get the correct care at the right time.
They won't get correct care at the right time. So we might miss out. We waste appointments. I like that, Margaret. Patients may not get correct care at the right time, which means it's very frustrating for the patient because, the worst thing is you come in, you waited 2 weeks for an appointment, and then you're told, oh, well, I'm the practice nurse, I don't see that. Or I'm the nurse practitioner, I don't do diabetic checks. And you're thinking, oh, I don't, do wound care. And you're thinking, I've waited so long. So, it's frustrating for the patients if we delay their care and they're not seen by the right person. I can see some comments here, patient frustration, delaying the correct care and wasting time, wasting appointments. We do not have a lot of appointments. And if we can signpost patients properly, it means appointments are used, but those who need it for that specific professional. Remember, we talked about we have practice nurses and they can do your chronic disease management. They have specialist training in wound care. They do the travel immunizations. They do the childhood immunizations. We have the nurse practitioners. They often prescribers and they can see quite a range of illnesses. We also have our pharmacists. What do the pharmacists do in your practice? Do they just review medication only?
They review diabetic patients as well, asthmatic patients as well. Some of them do COPD as well. And yeah.
So historically, pharmacists started.
Do long-term.
No, carry on.
I'll do long-term condition reviews as well.
Because historically, they started with just reviewing medication. And then we realized they started specializing. In our practice, our pharmacist is a specialist respiratory pharmacist. Anything to do with respiratory, we send to him. He knows, he goes on all the training for that. And some pharmacists, prefer like cardiovascular or hypertension. So they manage all the hypertension clinics. So pharmacists can do different roles, but now we've also trained pharmacists to do minor illness, which means they can run minor illness clinics as well. And even though they're pharmacists, that doesn't mean they can prescribe. But now that they've done if they've done something called the V300 course, it's a prescribing course for non-doctors, then they can prescribe, which means if a patient comes in with a cough or a cold or something that needs simple antibiotics, they can actually do that as well. And it's worth checking, can your pharmacist see minor illnesses? But really you need to remember as well when you're signposting is that even if an individual can see other conditions, what is their main task? Because their slots should be filled with their main task. Sorry, there's a bird outside my window here, and I don't know how to tell it to go away. But anyway, yes, they can discuss blood and urine results. So they can do quite a lot of different things. Okay, let me just going to make this smaller. And like you said, what happens when things go wrong? They get very frustrated, or care can be delayed, and that can be catastrophic. If someone comes in and they're very short of breath, and breathless, what would you guys do? The patient is very short of breath, very breathless, can barely say a word. And they're saying, can I have an appointment to see a doctor? How many of you would get, yes, I can see, flag it to the duty doctor. So if someone is very unwell, we talked about sepsis yesterday, or if we identify patients being very unwell, get someone to see them. If the duty doctor is not free, can another clinician see them? As healthcare professionals, we're all trained in basic life support, and find out in your surgery, what do the different practitioners do? Can you go and call them? Because quite often the duty doctor might be very busy, or the nurse practitioner or the practice nurse. Is there another professional we can call? And if you guys are ever concerned, call us. We might be a bit annoyed sometimes, like, why are you knocking on my door? But patient safety will always be paramount. So as long as you say to us, and be very specific, when you come and call us, you need to say, Jeshni or doctor or pharmacist or nurse, whatever, can you see this patient because I'm a bit concerned? Or like, someone has commented, your book on the day emergency appointment. If you think they're not well enough, can you keep them in the department until someone can review them and we can slot them into a slot? Remember, your job is not to diagnose. You're not responsible for diagnosing. You're responsible for flagging up if you think somebody is unwell. That's the main thing you have to do. Okay. So the NHS England care navigation guidance, it's really care navigation is about collecting information, assessing where can we send this patient to get them the best care possible in the quickest time possible. So can we, you don't want everyone. There was a time when I worked in A&E, and any patient who sort of coughed or sneezed was coming into A&E. And, at the time they told us, the admin staff sent us there. And then they're going to wait. They used to wait hours and then be told, well, you just got a cold, you can go home. So, we don't want to be sending people inappropriately or to the wrong places where they wait and time is wasted. And actually, we can actually change that by maybe sending them to Pharmacy First. Pharmacy First has been set up, and it's really great because they will see a range of things. And if you work in a surgery, find out which pharmacies are near you in your area. Pop into the pharmacy and say, hi, I'm admin or reception at such and such surgery. I just want to check, what can you guys see? Do you have like a trained pharmacist on specific days so we know to send them to you? Because then it means you can signpost. When I worked, I went and found out I used to walk around the pharmacy to see what they had on the counters. As a nurse practitioner, I could say to patients, in the pharmacy, they have that over the counter. Or I could actually, I used to speak to the pharmacist and say, what do you guys do? What can we send to you? Okay. It sounds like a lot of work, but it will help you in the long term if you can get patients there. And also, you don't want the pharmacy or the local urgent care phoning and shouting you and saying, why did you send this patient with a leg injury when we don't have x-rays? Or why did you send children to our urgent care when we don't have any pediatrics in this urgent care? So you really need to know, what do the local services offer in your area? So this is why you have the training. Okay, so you're part of the clinical safety system. You are the first point of contact. You are pretty much the gatekeepers, and you help navigate the ships through the harbor. Who goes where they should, where they should be actually stationed for the best appropriate care. Okay. Macready and colleagues, they offer that assistance offered to patients and carers in navigating through the complex health and social systems to overcome barriers in accessing quality healthcare. So really, it's about making a patient's journey as seamless as possible. And I want you all to think about your own experience trying to get to your doctor or get an appointment. I never realized, because I work in healthcare, I work between urgent care and general practice when I'm not teaching. I was once unwell and needed to get some tests done, and it was very frustrating. I went through the whole e-consult, and I was told, okay, you need to go to A&E. And so, of course, I thought, I don't think I really need to, but I will go because I've been advised I need to go to A&E. So off I went to A&E, and A&E said, what are you doing here? You should have been seen by your GP. This is a GP case. So blah, blah, blah. After waiting hours in A&E, phoned back to the surgery, and then they said, well, actually, we close now for the weekend. You need to call out of hours. And of course, you call out of hours, and they say, well, this is not appropriate. This is a GP case. So you go back on Monday morning. You're waiting from 7:30 to phone the GP to try and get an appointment. And then you eventually get an appointment, and you put to, say, the practice nurse. And you see the practice nurse because it's just, say, if it was a lady's problem or it was something that seemed very simple. And then the practice nurse is saying, oh, well, no, this needs a GP. And by the time you actually see the GP is 2 weeks later, you're very frustrated, you're already very concerned about your health. So we need to think about it when we send patients. Is this the best place for them? And we don't want them to do unnecessary runarounds, because then they're going to complain, and then they're going to be very frustrated, and then they also won't have much trust in the system. And we want them to trust our system, because, I've lived in lots of different countries, and no matter what you say about the NHS healthcare, we have a very good system. You try going to the US where you have to pay for healthcare. I live part-time in Sweden, which healthcare is free, but I think the healthcare in the UK is much superior. I'm saying that because I'm a British citizen. But, I just want you to realize, often people think it's better elsewhere. It's not necessarily. I've lived in 4 different countries. We still have the best healthcare system, and when it works well, it works very well. So general practice, it's really about improving access to patients. And this is why, what are the different ways you are improving access to patients? How can a patient contact you? You can type in chat or tell me. Well, I like this. So one of you stated there, we created a referral to local pharmacy who will contact patient, or patients can go there for referrals. Excellent. Yeah. What was my question? See, I've forgotten it. I'm getting old. What is the question I asked? Yeah.
You asked that how the patients usually contact us.
Yes, exactly.
I
So
think
what are the different ways? If a patient wants to make an appointment to your surgery, how do they contact on? AccuRx link, perfect. eConsult,
Yeah.
eConsult.
AccuRx for us.
Phone,
Email.
eConsult, Anima. What's Anima? I don't know that. Anima. Person who's written Anima, can you tell me what that's about? I'm not familiar with that. The online portal. So can you see? I mean, in the old days, you had to phone the surgery or walk in, but now there's all these different ways. What do you think is the problem with patients trying to contact us through the AI system, through AccuRx, through eConsults? Where would we have problems with that? So this is the first step where patient is trying to get through to you. What do you think would be the problems with them trying to get to use? Or who would have problems?
Elderly patients. LD patients.
Elderly patients. Somebody else said something else?
I'm sorry, my name is Irene. I was saying like she said, elderly patient. So not everyone can use online access, because that's what we use at Lower Clapton. It's called Anima. It's an online portal where patient can put in a request and they get a call back the same day from the doctor. Okay.
I mean, that's the thing, isn't it? We're getting all these new systems coming in now. I tried to get hold of my GP, and I'm a bit older now, but I wouldn't say elderly yet, but so I'm in that middle group kind of thing where I'm not that I know a bit of digital, but not enough. And you try getting, if you're not familiar with the AI, and if you're not familiar with e-consults or accessing, it's very frustrating. And then think about it, if English is not your first language. Imagine then trying to navigate the system. So you need to think about that. Or it might be, we have where we were, we had a huge population of people who came from Ukraine and from Eastern Europe during the when all the problems had started. So we had a lot of Polish patients, Ukrainian patients. We had patients from, who spoke Indian languages. So can you imagine, if you don't speak English as a first language, how frustrating that would be for them? Then there's issues like, what are the things that could actually affect you being able to communicate effectively? Speech. Can the person speak? Can they hear? Can they see? When you get to my age, I can barely see anything, and I have to constantly be taking my glasses out. It's quite amusing. I went to my friends, we went to a restaurant, and next thing, one of us took out the glasses, and then we were sharing between us because we couldn't read the menu. So can we even see the paperwork? So one of the things you'll need to realize is that when part of your initial navigation process, when a patient tries to make an appointment, our forms very simple. Can they understand our forms? Make it very simple language. Is it the option to actually have translation? And I know one of the surgeons said to me, y'all had this audio translation app that y'all used. I don't know if it's any of your surgeries where it's a specific translation app that you could use, and you just played it, you spoke into it, it spoke to the patient, and the patient spoke back to you. What is the problem with relatives interpreting for us? If we rely purely on a relative, there's nothing wrong with them interpreting, but if we rely purely on a relative interpreting, what are the pitfalls of that? What are the problems that could arise?
You mean if the relative comes to interpret for them?
If a relative comes to interpret for them.
Okay, so they are not clinically trained, so maybe they do not understand what doctor is exactly saying, because of the medical terms. So maybe they can be a wrong message.
Exactly. Or even if they're giving information, if they're filling in a form or they phone on behalf of someone, is that are they interpreting things correctly? It's quite interesting is that if you're not clinically trained and somebody says something, then they'll be like, oh, I know what you mean. Have you ever had that when you say something and someone's like explaining it to somebody else and they're saying, I know what you mean? You think, no, you don't know what I mean. I'm saying something completely different to what you are saying. I love it the bit where a patient will talk to the interpreter, to like a family member, and they like have a 5-minute conversation, and then they'll turn to you and just give you a one-word answer. And you think, what did you talk about? Because the patient said something and the interpreter is saying, no, you don't have that. Or, they're like arguing with the patient. And this is why sometimes it's a bit unreliable using a family member or a relative. What you really want is either a member of staff or some sort of AI tool or some sort of interpretation service to help you. We can manage face-to-face interpreters. The only problem with that is when you live in somewhere, especially like Northeast London, but to be fair, anywhere in England, there's so many different languages. An example is I am South African born, okay, and which means I don't speak any Indian languages. And I always get called to speak, if someone is Gujarati or they're speaking Indian language and they'll call me and I'll say, I really can't. Or patients will talk to me in an Indian language and I'm trying to say, I don't actually speak. I speak 4 or 5 different languages, but not an Indian language, which can be frustrating, isn't it? So for the patient as well. So something to always think about as well. Okay, we're going to have a break soon, don't worry. Now let me go back into slides. So it's about understanding what's the patient's need. Filtering. Your job is a lot of filtering. Oh, sorry, Margaret, you were going to say something.
No, that's a long time ago. That's fine. Sorry.
Okay, that's fine. Oh, sorry about that. Okay. A lot of your role is about assessing, prioritizing, and allocating patient requests, deciding on what sort of consultation. Do they need a face-to-face? We have so many options. Do they need to come to the surgery? Can we just do a phone call for them? Can they be referred? Someone mentioned that you can refer to the pharmacy, and then the pharmacy would contact the patient. Can we refer to the multidisciplinary team? We used to have a MUDAS team where you could refer, and they would basically take on the whole social prescribing, management, physiotherapy, everything for the patient. So, a very busy slide that I put here, but really we don't want to just improve the patient's experience, but we want to improve your experience as well. You're there from 8 to 5 or maybe shorter shifts. It's a long day. You want to make your lives, you want to make work enjoyable, okay? You want patients to be happy and safe, and you want to feel safe where you work. You don't want patients shouting at you because they're frustrated, they can't get an appointment, or they're frustrated because they've been sent to the wrong place. You want to be able to help them, because that's why we're often in these roles. But most importantly, we want to align capacity with what the patient needs. So the priority is improve access to primary care. About 10 years ago, there's this big drive to really push healthcare. What we've recognized is not everyone needs to go to hospital. So I did a project when I was at the university where we had students, senior staff members come across from an example country is Japan. Before they had the tsunami, I don't know if some of you, I told some of you the story. Before the tsunami, if you were unwell, you went straight to secondary care. They did not really have primary care services. So they didn't have GP services or chronic disease clinic because they didn't have a lot of it. They were quite healthy. Most of them were farmers. So they worked in the farms, toiling the land. They were quite healthy individuals. When the tsunami happened, huge amounts of farmland was destroyed. Lots of funding went into the country. So people were given a lot of money. And they were saying, this is compensation for your farms. But because of the destruction, they couldn't go back to farm life. And so they were now not employed. They did have money. And then suddenly alcohol became a problem, smoking. People were now eating not as healthily. They were not exercising as much because historically they didn't go to the gym. What they did do was work in the fields the whole day, and so they were quite fit. And so suddenly, in Japan, they had lots of primary care problems like heart problems, diabetes. I'm not saying they didn't have it before, but the numbers were so small that they went to secondary care directly. Now they suddenly had this huge number of people with primary care, like diabetes, chronic diseases, and they were not trained. So they actually sent a lot of their staff to the UK, and we put training programs in. We worked with them to develop their training programs. And I remember at the time, they didn't even have nurse consultants, and we trained. This was actually 2008 when they first started sending people to develop their primary care services. So, we need to realize that priorities can change, the way we work changes. So, what is needed in your area. So the priority is, how do we improve access, reduce the pressure on doctors? We don't have as many GPs. There's a huge shortfall of doctors. But in healthcare, we've also realized that actually the roles in primary care doesn't have to be with just GPs. We have the intermediate care team, we have the district nurses, we have the community nurses, we have so many different people that can do these roles and free up GPs for the more complex cases. And so the NHS delivery plan in 2024-25 was really about expanding pharmacy first. I remember at the university, we started doing a lot of training for pharmacists, not just to work in a pharmacy, but to provide enhanced services in a pharmacy. So suddenly most pharmacists can see and treat. They have their consultation rooms where they can see patients. And that has cut off, when we do out of hours, we can actually in out of hours direct straight to pharmacy first. So patients don't even have to see the GP or come in to see us either. So there's 360 million GP appointments every year. That's 57.5 million more than before the pandemic. Now, I was talking about, about 10 years ago, how healthcare was and how we've evolved. Historically, in my days when it first started, everyone got a GP appointment. They came and everyone came to our clinics. But since the pandemic, and the pandemic was not a nice event, and it had catastrophic results, but it gave us a lot of learning. And some of that learning was about the way we work. And we've learned, like now, you guys are not in a classroom, but you're sitting in your homes or your offices, and you can do this training session and then maybe go back to work in the afternoon or go pick up the kids. Some people will have training sessions on while they waiting, for something. So now we realize not everybody needs to come face to face. We can work remotely. We can use other services as well. But it's quite worrying that instead of the appointments getting less, we actually having to give more appointments now. So there's something we're not doing right, but there's something we can do better, and that's what the training is about. If you look at the statistics, Newham, Tower Hamlets, these are areas where it's a very fast growing population, and also populations that move. People are working, you get a job, you move to a different area. Lots of younger people, we have lots more younger people, a younger population, they're faster growing. There's sometimes higher health needs, but there's also a high amount of unemployment, which actually has, an impact as well on healthcare needs of patients. Unfortunately, we have something called the inverse care law. And what we've actually found is that sadly, that sometimes in certain areas, there's a higher amount of people, but less doctors. What do you all think? There's a higher patient to GP ratios. Why could that be? Why do some areas just not have enough doctors or healthcare professionals working there? Any reasons you think this for happening? I'm just trying to see the chat back a bit. Okay, so really I was talking about this slide, about access, about our priority in the UK, the fact that we have much more appointments, okay? What do you think in Northeast London, we have fewer GP doctors per population? What could be the reasons? Any ideas, anyone? Let's see what you are saying. Highly populated areas unable to meet demand, sudden influx of people to a particular area. True. We know sometimes as well, if you have like council housing, you have like these lots of high-rise buildings with a larger population than a more suburban area, which has houses that are spaced out. We also found that from the statistics that sometimes in these areas, we don't have as much training opportunities. So when we have the GP training, they tend to be either more centralized near the universities or in the more urban areas, like in central London, and they're not in the more outskirts areas, which means, usually if we have student nurses, student pharmacists, student doctors, they actually help with the workforce. But we find in these sort of areas, from the statistics, that we sometimes don't have enough of that, okay? Then the other thing is, other issues, we have lots of other issues, is mainly workforce. And like some of you said, is that we have a higher population, and possibly sometimes, depending on the area, we have a higher demand on the service. And we may have the same amount of doctors as another area, but the demands in a specific area is what's making this, giving us more work and requiring more appointments. Okay, so that's covering the theory of care navigation. We are going to have a 15-minute break. And after this break, we're going to get into the fun bit, which is about some case studies and really looking at your role. But I wanted to set the tone of why we are where we are in terms of healthcare. So, this is from a statistical report, because I've been going through a lot of the data around Northeast London, and what are the reports, some of the reports are saying is that patients in Northeast London are generally more complex, and which can sometimes make it harder to assess, and then therefore there's a higher risk around this. And so it makes your role far more important. I just want to switch something off. Hold on. Okay. Now, some of the problems that do arise, especially in the area where you work, is the statistics have shown that 20 to 25% of the adults lack basic digital skills. And from what you have told me, that if everyone y'all are using AI tools, Anima, eConsult, Accurex, that is a big problem. If a quarter of your population don't even know how to access it, and this identifies that we do need to probably do more training, or even to ask patients, do you want help in learning in how to book? Identify, we do things like audits. Identify in your area is, we sometimes send out surveys is, do you prefer to do in our patient groups is, do you prefer e-consults? Do you prefer digital? And sometimes when patients come into the surgery and they want an appointment, or they call us, we need to identify why, because it's, I've had cases where they call us and then we say, oh, well, no, you need to put an e-consult in. The doctor will look at the consult, but you can't make an appointment on the phone. Or they come into the surgery and saying, can I make an appointment? And it's because maybe they don't know how to use the digital systems. And, they could be quite old school like me. I will physically come into surgery, or I will call a surgery. So maybe this is the problems they have. And one of the things is that I lived in Sweden for a bit, and I didn't speak the language. And I didn't realize, I always thought I'm an academic, I have lots of qualifications. So but arrogant, I thought everyone spoke English in a way. And then I went to Sweden and I was unwell. And even something as simple as paying my electricity bill, I did not understand what to do. And I felt so helpless despite all my qualifications. So we need to understand that sometimes patients, especially if they don't understand how to navigate the system, if they don't understand the language, they have the sense of helplessness, because you're thinking, I need care, I need help, but I don't know how to access it. And I actually thought at the time, if I didn't have my husband here, what do I do? Because I don't speak this language, and for all my qualifications and all my masters and degrees and stuff, it's no help here, because nobody understands me. So if your patients do not speak English, and they may speak lots of different languages, if your patients are older patients or even younger patients, we have a lot of people who will specifically I avoid things like Instagram and Facebook where I can. I make a point that when I wake up in the morning, I don't look at my phone for the first thing. I try to read something, and it was very hard to do that, to try to get away from the digital. So, there's all of this as well to think about. Did you know in Newham, there's over 100 languages spoken? So what do you think could be the problem if we have so many different languages in an area? What do you think is the issue with living in an area, working in a surgery where we have about 100 different communication gaps? And what happens with communication gaps? Why is it a problem if we miscommunicate? So, I was telling you my story about Sweden, and I got a builder in to paint a wall. And oh my God, it was so difficult, because he was saying one thing, I was saying another thing. And and then we realized that he just didn't understand what I was trying to say to him, because we are speaking different languages. I have terrible Swedish. So, it was, so one, we need to think about it. If we don't speak the language, what resources are we using? Are we using Language Line? Are we using the apps? Are we making sure we understand patients? And also, some patients are not very comfortable. Someone's mentioned it. They're not comfortable talking about certain aspects. It might be a cultural thing. They don't want to talk about it. Or they feel uneasy. And especially now you're trying to type it into an app as well. So remember that if you don't speak the language, you need to be very clear. You need to give very clear instructions. You do not give complex instructions. Something I've learned is, do not say a lot of instructions at once. Give one instruction. You have an appointment at 10 o'clock with the practice nurse on this date. Avoid things like, you have a 10 o'clock appointment with the nurse, and after the nurse, you're going to do this, and after that, you're going to do that. Speak clearly, be factual, get to the point. Sometimes we try to be nice and we give too much information, and that can cause confusion. So we need to remember, if English is not someone's first language, give very simple, clear instructions. Okay, well done. One of you have said, use simple sentences. And this will reduce the chance of miscommunication, not identifying what's going on and missing red flags. And quite often the people who are struggling to access our care are the ones that actually need it. These are the patients who really need it, and that's why we don't want to be missing out on what's actually going on. So remember, your job is to identify risk early, and we want to be fair in how, and we want to manage uncertainty safely. So we want to actually try to manage patients, because what we don't want is a clinical incident happening. Something happens because someone miscommunicated, we didn't understand the patient, or we signposted the patient to the wrong person, and it was not the most appropriate care. We didn't take the patient's symptoms seriously enough. It could be a case, some patients will come in screaming and shouting, "Oh my God, I'm in pain." Other patients, they have chest pain, but they just come in and say, "Oh, I have a bit of tightness in my chest." And, they not expressing themselves as much. So we need to learn to pick up on cues and to ask a bit of questions so that we're signposting them to the right place. So safe navigation. Remember, we don't want to just manage demand. We want to manage risk, and we want to keep our patients safe. So it's all about making decisions that will improve a patient's access, address any health inequalities. So you are doing health inequalities this afternoon. What are the health inequalities where you work? What would you identify as a health inequality? There's a very good response here. The interesting part is stakeholders are not being informed about digital services, and they only get to know while they are coming to the practice and being informed. This might be quite difficult with the recent changes. That's the thing, is when we change what services we offer, are we letting the public know? Not everyone goes to a patient, a practice patient group, PPG basically. Not everyone goes to these meetings. So are we finding avenues of alerting patients of how to access us? Are we letting other stakeholders know what services we offer and how we run it as well? Just 1 second, I'll almost close the app again. So what are the health inequalities that you see where you work?
Maybe the health inequality would be like if we misinterpret that which patient needs the care more urgently, or if we just choose ourselves that, for example, the person is elderly, so that person needs immediate care, and ignoring the one who is maybe 30 but actually needs the care. So
Exactly.
yeah, so
Very good answer. Because it's about our care being equal, and we should never discriminate that someone is too old or too young. I was doing a lecture yesterday, and I mentioned that I resuscitated a 24-year-old once. He came into the department with chest pain, and our policy, and this is why we have policies where we work, our policy stated that if you had chest pain, you got an ECG. That was the policy at the time. And wherever you work, you'll have policies and protocols saying if a person presents with blah, blah, blah symptoms, then you call 999. If they present with certain other symptoms, you might call a doctor or you might call a nurse, so when to escalate. We do a lot of that. So the important thing to learn was that this guy was actually having a heart attack, and he was 24-year-old, is a 24-year-old. So usually you think, okay, if he's a 60-year-old, overweight or smoking or whatever it is, stresses and stuff, high risk factors, he's going to be the likely one. But actually this young person, so if this policy is in place, you need to adhere to them. Okay. The other thing is good documentation, is documenting what you do, and confident communication. Oh man, and we talked about that. So what the current system is around single point of access models. What we're really looking at, instead of patients having to phone here, phone there, it's really frustrating where we have to phone 10 different people to get one result. And what we are really moving to in healthcare is we have a single point of access. So patients will contact their GP, and that's going to be you in the first instance. They're going to call you, they're going to set a consult, or they're going to turn up at surgery. And we are then going to direct them to the best and the most appropriate care. So they contact one place, and now it's not about saying, do we have enough appointments? Can we slot them in? That's not the way we work now. Now it's like, where is the best place for this patient to be? Okay. So if a patient comes in with a sore throat, historically you would book them with a GP. Now you can send them to pharmacy first. Remember again, you're not diagnosing, you're not taking a clinical history, but if a person is fairly fit and well, you can say to them, We do have pharmacy first, where they actually can see and treat a sore throat. Okay. We do have the physio. Can I make an appointment with the physio for you? We have a mental health nurse available on a Tuesday. Would you like to speak to her? Sometimes if you feel this is not really my area and I'm not sure, ask advice from one of the clinicians. Speak to one of the doctors or one of the nurses and say, I have this patient. She's not saying she's suicidal. She's feeling very low. Is it okay if I put her into a mental health slot? And they may say to you, well, actually, let me have a chat with the patient and we'll make a decision from there. Okay. So this is where the additional roles reimbursement scheme, and this is why there's been this big push to have all these different professionals in to support healthcare. Okay. Now there's reimbursement if you're employing paramedics and pharmacists and physiotherapists. Basically, it's about managing the GP demand. And so the R's roles in practice is your pharmacist, your physio, your social prescriber, your mental health nurse, a practitioner. We have district nurses, which is great because sometimes with district nurses, if it's, the patient's relative has called and said, my dad has this leg which is oozing and it needs a dressing, can the district nurse be contacted? Can we do a referral to them to manage this patient at home? If there's a history that the person is falling a lot, they've been assessed. We have a falls team, we have frailty services, we have palliative care services, someone with cancer, or they have they come into the end of life because of maybe a condition they have, and they need a bit of support in terms of pain management. There's a palliative care team we have. And this is a very important one, the voluntary sector. We found, we did this project, and our over 75s nurse and the paramedic would contact patients over the age of 75. What do you think are the issues that when you're over 75, what are the things that you could experience? All of you look quite young here. So 75, what are the issues that arise? Just generally
Maybe
speaking.
heart problems, joint pains, and
Yeah, it's like you become like an old car, isn't it? Everything starts to fail. The warranty is gone, and your heart is working harder because it's been working for so long that now it's starting to fail a little bit. Your joints are starting to hurt.
they
You
heal
have this.
slowly, like they do not heal really fast like young people do. So they're most likely to be housebound for a long time. So they need these kind of care, like
It's a bit of the thing. You know that if you want your bones to be strong, you have to move because our muscles attach to our bones, and every time we move, our muscles, the movement of your muscles makes your bones increase. The actual building blocks of bones will increase. So, like in the old days, if you had an injury, we just put plaster and say you don't move. Now we're saying move. Now, what happens when you're older? You're shuffling, your movement is not, you've got lots of pain, so you don't move. And then what happens? If you don't move, your bones get actually much thinner. So if you do fall or bump into something, you're going to break it more easily. Okay. So it's like, you're not winning there, are you? Health deteriorates, and someone mentioned feeling low. Why do you think you could feel low? What's happened when you're about 75, 80, 90? What else is happening in your life?
they get more lonely. Most of the family members have moved out, or maybe the partner has passed, or
Yeah.
things like that. Yeah.
Yeah, the children are busy, someone actually said to me, she said, most of my friends have died. She was about 80 something. She said the friends had died, her husband had died, the kids had moved on, they'd either gone overseas or moved on with their lives. And, and she didn't want to become a burden. So you need to think about that sometimes with older patients, when we see them, and there's that opportunity we have is that not just think about their medical problems, but their social problems. So we actually started getting patients we have age concern. And like age concern used to do this thing where they had the weekly bingo nights. And on Fridays, they used to do little trips to different areas. And it was really subsidized. So patients could go off on trips and then they met new friends. They got to play games. They did some volunteer work in the local charity shops. And that would keep them going as well. Are they aware of that? And that is what a lot of social prescribing, it's not about doing CBT or just giving you advice on going to the gym for your weight, but it's really managing these patients who feel very lonely and isolated. And it could be from age, it could be from because of language. And, if you identifying that is, can you address that? Because that would mean that person, one, may not, will eat better, so they'll take better care of their health. so they're less likely to come to the surgery. We also have, now we have virtual wards where we have teams, and usually like they will, when I refer to the virtual ward from the out of hours, they usually go within 2 hours to see a patient. Is this something that can go to the virtual ward team? They will go to the patient's home, and then they will set a care plan up to manage the patient for the future, and they will handle a lot of it. So we have all these different services. We have, and then, there's lots of routes. What are the other services you guys have that you can refer patients directly to, so they don't need to see a GP appointment? Can you think of any other services you'll have?
We have wound clinics. We
You
have
have the wound.
sexual health clinics.
Perfect. If it's an
And
STD, why wait to come and see us? And they, it's a bit embarrassing when they can go to the STD clinic. Yeah. I don't know if you all heard about the SARC team. So SARC team is a sexual assault and rape center. And if someone comes in saying they've been assaulted, sometimes if we are females, they might disclose to us, or if you're a male, a male might disclose to you. It's called SARC. It's in every area. And basically you contact them. They will come in. The patient can wait there, or the patient can give an appointment. They'll see them. They will assess the patient. They will take all the samples they need. They will help them through the courts. So it's quite good to know that, if there is abuse, you have the SARC team. If there's any safeguarding and you think, I can see there's something not right here, but I don't know what to do, and I don't want to get involved. Well, your job is to get involved. Not directly, but at least alerting someone. I'm a little bit worried about this patient. This patient has come in quite a few times with bruises, or this child is coming quite a lot during school hours, doesn't seem to be going to school. If you see these things, alert safeguarding team, alert clinicians, so we can actually look out for it as well. Because remember, you might be the only one that actually really helps that patient or notices something. Okay. And remember, our role is about asking basic questions. So can you tell me what's going on? Because what you really want to know is, you're not doing a consult. What you're really checking is, how urgent is this, and where's the best place to send them? Okay. So you're about identifying the right pathway, and you can ask basic questions. I know I had a sheet, like a little crypt sheet for the reception staff to ask patients, like, some very basic questions, so we got a bit more information. So if I read the notes, at least if a patient said anything extra to you and you put it in the notes, I can use it. And sometimes it helps me in determining, do I need to get this patient in to see me? Is it enough for me to phone the patient? And any information you put to us always helps. Okay. So the main thing is, if the patient has an immediate life-threatening condition, what would you say is an immediate and life-threatening condition? Give me some examples of what you'll have seen in practice. Oh yeah, someone from the earlier conversation, you'll mention eye clinics, out of hours appointment. Perfect. So what coming through the door or calling you would say, this is an emergency, it needs to go straight, we need an ambulance. Chest pain, breathing issues, gasping for breath, can't even speak. Yeah. What else could be an emergency? Patient is bleeding. Yeah. Patient is bleeding quite a lot. Even menstrual bleeding or bleeding in pregnancy. That's not, because what you need to think about is, can we manage this in the surgery? Does this need something else? And if you've got chest pain, we need to do an ECG. If you've got breathing problems, we need to listen to your chest, but we also need to maybe do a chest x-ray. Abdominal pain, is it like appendicitis or something really bad that might need surgery? Do we want to waste time with the patient sitting in here? If you're on that verge of thinking, I don't quite know, the patient looks unwell, but not unwell enough to call an ambulance, speak to your duty doctor, or speak to one of the clinicians and say, I have this patient on the phone, or I have this patient in the waiting room. I'm a little bit concerned. They don't really want an ambulance and they don't want to go to A&E. Do you mind talking to this patient so that we can assess, do they need an urgent slot? What can we do? But sometimes patients are saying to you, I don't want to go to a hospital. If I go there, I'll die, because everyone I know of, when they died or they got infections. Yeah, good points that you made. Sometimes the patient is very distressed, or mental health conditions where they are seeing or hearing voices that's telling them to harm themselves. If the patient is so distressed that they are threatening to harm themselves, so then, do we need a crisis team? Not 999. We probably need a crisis team to come and see them. So you need to think about is, if I send them to hospital, is that the best place for them to be? Because you don't want to be sending everyone to a hospital, and it might not be the most appropriate. So there's this flow chart. You will get the handouts and you can look at that. Okay. Do they need to call 999? Can we send them to another service? if they have a long-term condition, is this something that can see the practice nurse or any other professional? If it does need to be done seen today, does it need to be by telephone or face-to-face? And who does it needs to see them? Does it have to be a doctor, or can it be any other healthcare professional? You cannot put people into slots simply because a slot is empty. You put them into a clinician slot because that person is the best person to see them on that day. Because quite often I used to sometimes find the slots would just get filled up, and then you think, this is not appropriate for me to see, So just a little guidance on care navigation and the flow charts on what we use and how to signpost. Now, do you guys have any duty of care? What do you all understand by a duty of care? Tell me what you all think. What do you all understand by, do you have a duty to anybody? I mean, you have a duty to come to work on time and to do your job, but what is your duty to patients? If something goes wrong, do you think you're accountable? So what is your duty when you're working in surgeries? Are you accountable if something goes wrong, and why? If you all can't unmute, can you all type into the chat? You have a duty to give appropriate care. Yes, as frontline staff, you have a duty. What about if someone is collapsed out in your parking lot, the surgery's parking lot? Do you have any duty to them? Call the duty GP, yeah? You can call 999, yes, if someone's collapsed outside. So remember, if you're in a GP practice, and the rule is this, if anybody is in your waiting room or is outside in the parking lot, we do not expect you to go checking your parking lot every 5 minutes. But if you happen to see somebody unwell in the parking lot, you have a duty to stop and help them if you are in the surgery. So there's no common law duty in the UK in the sense that you don't have to help everyone you see on the street who's collapsed. However, if they are within the premises of the GP practice and it's within your working hours, then you have a duty to help. I used to sometimes have to run with our emergency bag to the local pub, to the people on the road, because we're within the proximity of the GP practice. So we have a duty to report or to escalate it, okay? I'll tell you a little story about duty, okay? So you have an absolute duty. You're the first point of care. You can influence access. The moment a patient phones us, sends an e-consult to us, that is when your duty starts. Okay, I'll give you an example. I'll give you a little story. So this case was a case that happened in central London. 3 security guards came to the hospital and they said they have diarrhea and vomiting. Okay, so their issue was they had diarrhea and vomiting, and the security called the emergency department and spoke to the A&E sister. And the A&E sister spoke to the A&E, the senior doctor there, and he said to her, "Oh yeah, tell these men go home, drink fluids, and if they don't feel better, come back." So these men went home, and actually they died. But did this doctor or nurse have a duty to the patient? Because they didn't see the patient or talk to them directly. But did they have a duty to them? What do you think? Let's see what is everyone saying. Did they have a duty to these patients? So these 3 men came. You know how it is to the main hospital entrance, A&E is at the bottom. It was late at night. Security called and said, I've got 3 men here. So yes. So I've got one person saying yes, that yes, they had a duty. They didn't actually see the patients, but they gave advice over the phone. And this is the danger, is if a relative is calling, a family member is calling, the carer is calling, the moment you signpost to give advice, your duty begins. Even though you didn't speak, wherever I can, I try to speak to the patient. I'll say, "Oh, is Mr. So-and-so or Mrs. So-and-so there? Can I speak to her? Because I want to know, are they alive?" And you will be accountable, because remember, the moment, this is why we had NHS Directive on stage, was they had a set of protocols that they used, is that if you're giving advice over the phone, we need to be very careful. The moment we make contact, the moment the patient phones us, our duty starts. The moment the patient walks into the waiting room, our duty starts. If you are working at a surgery and you are outside the surgery door, but within the premises, and somebody asks you advice, don't just fob them off and say, "Oh, whatever." Just say, "Look, I'm sorry, I'm on my lunch break," or "I'm sorry, blah, blah. Can you go in and see one of our staff at the desk, see the reception?" Don't attempt to give advice unless you're willing to accept that. Then you have a duty of care to the patient. Is that clear? Do you all have any questions around duty of care? Now, your duty is to act in a reasonable way to avoid harm. Because in law, we use the law of torts, which is a law of negligence. And that says that for you to be found negligent, you have to have a duty. You need to breach that duty, and harm has to occur. So sometimes harm can occur even though you don't breach your duty. in this case, like, that nurse and doctor, they were held accountable for this, right? And it was taken to court. So in court, it was shown they had a duty of care because they should have seen those patients or assessed them themselves. The security guard was not a clinician, so couldn't make the decisions and shouldn't have been asked to make the decision. And he had done his job by, if the security guard at the reception had told these patients, oh, off you go, the A&E is busy, and these guys died, he would have been responsible. But he escalated it, okay? Because he phoned the clinicians and asked them advice. And that's quite often your role, is that if you are not sure, you will speak to a clinician and say, I have this, I'm not quite sure of what to do. Because then your duty, you're transferring your duty to this clinician. But the moment you decide, oh yeah, it just looks like you got a panic attack. Yeah, I know you're wheezing, but it sounds like you just have a cold. Go home, everyone's got it. You can't do that because that is not within your scope of practice. Your job is to identify, is an emergency? Do we need to refer the patient on? What it means is you must act reasonably and safely. You must follow training and protocols. And so this whole thing of duty came out of a case called Donahue versus Stevenson. Basically, this lady went to the pub and she bought a ginger beer. When she bought the ginger beer, she found a snail at the bottom of the beer. So who do you think she would sue? The pub owner or the manufacturer of the beer? Who do you think the duty lies with? The pub? Let's see. I'd like to see some pub owner present. Okay. What are your other thoughts? Who is responsible? Because she bought this beer from the pub. Is the manufacturer of the beer responsible for the snail in the beer? Or the owner of the pub? He opened a sealed bottle of beer and gave to her. The bartender, if you put it into a glass, yeah, but this was a sealed bottle. You just take the cap off and give it to them. So it is a ginger beer, actually. So the actual person she sued was the manufacturer. Okay, because duty starts the moment is that if you take on a role or responsibility, so the brewer of the beer, not the pub. Daniel, you've got it right. The manufacturer, so Foster as well. The person responsible for that initial product or decision, okay, and this is where you guys come in because you are the front line and you're deciding where people are signposted to, in a way. The manufacturer is responsible because when the clinicians do online, there's not enough information. Whose duty is to find out what's wrong, the clinicians or the non-clinician staff? The clinicians. What we do have, what you can do is you can actually say as admin staff, you can say, you know what, you could possibly say, we need this a bit more information on these forms to help us with navigation. So you can actually help with getting the forms changed. But anything clinical, whose duty is it to find out what's wrong, the clinicians or the non-clinical? When patients do online consultations and there's not enough information, if you are unsure, then you can contact the patient and say, if there's anything in the information you think is not clear and you can't decide, you can ask the advice of a clinician or you can contact them. So duty is partly yours there in terms of who has created this form. Do you need to speak to the admin manager or practice manager for this? And that's where you would look at it. So duty is about the fact that if you are at the front line, quite often duty lies with you. And that is why they send you on training and they highlight the sepsis training was really about how to identify someone who's got sepsis, how to identify situations where someone's very unwell. And that's where you'll do the session on safe triage and boundary setting. How do you triage patients properly? How do you recognize? You go on training. What is your local protocol in terms of managing it? If that e-consult form does not give you enough information, can we change it and make it simpler? Do we need to call this patient and say, you sent in an e-consult, but actually we need more information? But the thing is, it's a bit of a difficult one because with e-consults, the duty GP normally assesses, screens it. Who do you all have screening it? Okay, let me just check the chat box there. Yeah, I see there's some comments here saying we usually call the patients and maybe they were unable to write down what they need. Yeah, and sometimes you have to do that, is pick up the phone and call them. The easiest thing sometimes is to just pick up the phone and make contact with the patient if you can. And that can save a lot of misunderstanding and miscommunication. So in law, for you to be found responsible, we need to show that you had a duty. And the moment the patient contacts us, your duty starts, that you breached it. And the breach means that you either didn't escalate it, you didn't send them. Now, it won't matter too much if you don't send them to the right service. So just say you send them to the practice nurse because you thought she was the best person, okay? Or you sent them to the nurse practitioner and you didn't realize the nurse practitioner didn't see this particular, but at least you sent them to a healthcare professional. So it's not about breaching it that way, but when it's a breach, it's things like the person is very unwell, or the person they can hardly breathe, and you've decided, oh no, it's nothing. They can just go to they can just go home. It's like someone comes in and you say, no, go home and take some pills, go take some paracetamol, and you're referring them on without having assessed the situation appropriately. That is when you are in breach, because then if harm occurs, it's going to be, you're going to bear some degree of responsibility. So redirecting patients to a pharmacy, is this the most appropriate thing? Are you sending them to the pharmacy because there's no appointments available? Or can the pharmacy actually help them? When you ask a patient about their appointments, are you maintaining confidentiality? If a patient is saying they're very unwell and they look unwell, do you put them in a routine appointment? Because you can sometimes put them in a routine appointment, but highlight it and say to the clinician, I've stuck them into this appointment, but actually they need to be seen now, okay? Or they need to be seen urgently. So have you followed it up with steps to say, we need it seen more sooner? When you're doing telephone triage, are you following the policies? When a patient comes repeatedly, do we get fed up and say, oh my God, not you again? And, oh, this person comes to the surgery every week. They're crying wolf. I always find out, sometimes when I do out of hours and I see a patient and it says they've called for the 4th time in 2 days, and you get a bit of a heart sink. But now I do this, I think, why have they called? Are we failing in some way that this person keeps coming back? Are we not addressing their needs? So what are we doing wrong? Maybe we're sending them to the wrong person, the wrong clinician. So Health and Social Care Act of 2008 says that we should always provide safe care and treatment. The Equality Act is that we cannot discriminate. So things like, you can never stand in court and say, I didn't understand the patient. Well, the patient couldn't speak properly or couldn't hear. That's not my fault. What did you do? What did you do when you identified that this person couldn't hear you, or couldn't speak the language, or couldn't communicate effectively, or didn't understand? Do you all have systems in place? Did you tell the admin manager, actually, this is a problem that I found, and what have we done about it? When you all have meetings, are you addressing, actually, when we're down, and I always, this is why I used to sit down at reception, because it gave me a feel of the problems you guys have down there. It's like, well, it's all very well that you all say we should signpost, do this, but these are the issues we are having. Can we change the paperwork? Can we change the e-consult? Can we add this or take this away to make it easier for patients? So how can you contribute to making your job in signposting better and easier? Okay, so what's the time now? 2:00. So data protection is that we keep all information. How are we storing information? Is it safe? If you decide to refer somebody, how are we sending information on? So how do we share information? Okay. How are we storing information? Do we leave the screen open with patients' data on our screen? So the moment you're moving away from your desk, are you taking out your smart card? Are you closing your screen so nobody else can read the information? Because none of us have any business going and reading other patients' information if we are not dealing directly with them. As healthcare professionals, unless we actually dealing with the patient, we don't just go into their notes and just go and read through. Because if we're not actually dealing with the patient, why are we looking at their notes? If we are working with another clinician, then yes, we might have to look, because we are sharing data to share information. And this bit also comes into, if you do find somebody they need to go to hospital, you will only send the information that's important and relevant. So what is important and relevant information? That someone's collapsed, you've called the duty doctor, you've called the ambulance, and the ambulance is on the way, and you've given the doctor some equipment, and they all are busy with the patient, and you've been told, print out a copy of the patient's notes. What would you print out?
And their full name, their date of birth,
Okay.
and their ongoing problems.
Yeah. What else?
And maybe the current medications they are taking, which might be useful for them.
And I've got your medical summary. Well done, everyone. That is what you want. And Margaret, you said brief summary, which is perfect. We do not need to know their history from 20 years ago. We need to know, have they been hospitalized recently or had surgery? Are they allergic to any medication? What medication are they taking at present? And if the medication is not being changed in the past month, we don't need reams and reams of repeat prescriptions. We want to know what medication they are today and in the past month. So you need to just put a brief summary record. And if we need more information, the hospital will contact us. But do not, I remember once somebody printed 50 pages or something. And I thought, no, what if one of these pages runs loose or falls out and the public can see it? So we need to be very careful. What about the fact that, okay, you need to refer a patient on to any service and you phone them? Should you make the phone call from the front desk or somewhere more private? And you're the only reception on duty at the desk because everyone's gone to lunch, but you have a full waiting room of patients.
Back desk or somewhere away from that desk.
Somewhere but private. Well done, Nicola. You need to do it somewhere private, because think about it. If you're quite often in an area, patients know each other. They are neighbors. Our GP surgeries are such that individuals may know each other. I remember we had a really bad incident once where we had 2 reception staff talking about a patient in our A&E department who had died. And they were talking about how, it's so sad that, he was 18 years old and he had died in such a tragic way. And they were discussing the whole thing. And the patient's mother was sitting in the waiting room and she hadn't been told as yet. So can you imagine that? Now that's like a really extreme case. But imagine if someone's discussing, you're referring to STD clinic example, and you're giving this patient's details, or somebody who's pregnant and miscarrying, or it could be anything. Nobody wants their data shared. One of the things is like when we do telephone triage, we shouldn't nobody else should be listening to our conversations, because especially when we're taking information about the patient, it's like, hello, can you confirm your name? Oh yes, it's 10 May, this thing. Can you confirm your date of birth? Oh yes, you're Mr. Smith. Can you confirm your address? And then you're shouting out all the details. And what I used to hate in the very old days, when the reception will say, what's your date of birth again? And you have to shout it over. And now at least I'll give you a piece of paper to write on. Or you have the screen where you can just put your details on. But think about confidentiality. Think about protecting patients' data. What about if you were there? Do you really want to be shouting and telling them about, it's like, what is wrong with you? Tell me what's wrong. And the patient's like, oh, if they're mumbling, maybe they don't want to speak up. So maybe you might have to step away from the desk and say, would you like to talk about this more confidentially? Or, are they a bit shy about speaking about it? And try to avoid. And this is why we often will say, like, the rest of the patients will stand away from them so they don't have to hear. Because they might want to tell you something private. They may make up something else because they don't want to tell you what's actually wrong with them because they're a bit shy about it. Okay, so think about when we're actually taking information and navigating is how are we speaking to patients. So in law, you can share information, okay, with the patient's consent. If they agree, you can share. If it's in the public interest, so if the patient has disclosed to you that they want to harm themselves or others, we can share information with the safeguarding team, with the police. If we think there's a safeguarding issue, so we think that someone's being radicalized, we think that there's female genital mutilation because they're giving a history like, oh yes, we need the travel medication, we're going away to, say, certain country for a certain amount of time, and you think, oh, I know this family and this child looks uneasy and I feel a bit uncomfortable, report it. You think there's domestic abuse or this thing. Now you cannot just say, oh, this is happening. But if you have concerns, you have a duty to report. In terms of records, you know that for children, we keep their records for 8 years after their 18th birthday. So pretty much 26 years. For mental health patients, we can keep it a very long time as well. So we keep records for a very long time. Anything you write on records can come back to haunt you years down the line. So make sure you keep records safe. You don't write unnecessary information, and you only put information that's relevant to that patient. Okay. A daughter calls reception. She says, I'm calling about my mother. She had some tests done. Can you tell me the results? What do y'all do? So now, what do you guys do?
You'd have to check whether the daughter is the patient's next of kin. Otherwise, we can't give the information.
She is the next of kin. What else do you want to check?
We want to check if the patient has given consent for her to speak on her behalf.
Exactly. Has a patient agreed for you to give, we must get consent. Anyone over the age of 18 can agree or disagree to things, okay, even if they make bad decisions. All patients can give consent. Even children can consent to things, okay, and we have laws around that as well. Is the daughter okay? Is the mother okay with the thing? Maybe she doesn't want her daughter to know her blood results. Maybe she doesn't want to share information. What about if a husband calls and says, my wife had some tests done. Can you tell me what tests she had and what the results are? What can you do then? Can you tell him anything?
No, until we have any information about the consent, if they can share the information to their family members.
Yeah, but you see, my wife, I'm responsible for her, and she doesn't really speak English. It's not her first language. So I usually, I need to know everything. So can you tell me? You need to tell me now. What then?
We usually ask them to come to the reception or maybe call us
Yeah.
themselves to speak to us, or maybe call them on the spot and take their consent and then move forward
Yeah.
with their request.
Well done. We need consent. So you might have to say, can we speak to your wife on the phone? And if she does come on the phone, we need to clarify details. But remember, there's this thing about we don't know if blood results are normal or not. So you really want a clinician to be making that. She needs to call results line because we are not clinicians. That's well done, Tino. You're not clinicians, so you can't say whether the results are normal or not. You can either make an appointment, or in some cases, if you have the results line, they can call and speak to a clinician about the results. So, you are not going to be giving results on the phone anyway. So what about this one? Oh, who wants to read this for me so it gives my voice a break? Anybody feels like reading? Yeah, go for it, Margaret.
Patient says loudly at desk, I have got a urine infection again. Can I get antibiotics? Yes, you had one last month as well, didn't you? Patient calls.
We can stop that. Sorry. No, stop there. So someone calls and says, I've got a urine infection and I want antibiotics. Is it your job to say, well, you had some last month, didn't you? Is that your role to say something like that? Can you make that decision about when they had? What are you going to be asking them? You could ask questions like, have you had this before? Because what you're determining is, if it's the first time, they could see the nurse practitioner, but maybe the protocol is that if it's a second time, they might have to see the doctor. Or if it's the first time, they can go to even, see the pharmacist or go to pharmacy first. So what is the protocol where you work? But what we need to be careful is we are not clinicians. I mean, you're not clinicians. So we just need to be a bit careful about what questions we ask and any advice we give. If a patient calls and says, I've got a sore throat and feel unwell, what you want to do is say, can I just ask a few more questions to make sure you're seen by the right person? And this is where you don't need to ask. I don't expect you to doing a clinical assessment, but you want to just get enough information to decide, does this go to pharmacy first or okay, so let's go. Patient says, I've got sore throat. What in the patient's history would make you think, okay, this can go to pharmacy first? Give me some examples.
In our surgery, we don't make that decision. I have to send the request. If it comes through on the ActuRx or the e-consult, we send that to the GP, and then the GP makes the decision whether it needs to be signposted elsewhere.
Oh, perfect. That's very good. In some surgeries, you can, the patient's like in front of you, not looking distressed. You can probably say, we do have pharmacy first available. But most of the time, when it's anything clinical, be more inclined to get your GP to see them or to have, a clinician see them. If it's e-consults, it's easier. But when they're standing at the desk, if you do ever take information, you're taking the minimal amount of information, just enough to signpost or to refer to the GP. Okay. What about a patient says, okay, you're the receptionist. I don't need to tell you anything. Just book me in. I want to see a doctor. Just book me into to see the doctor. What do you do there? What assessment would you do, basically? It's like, stop asking me so many questions. You're not a doctor, are you? Can you just book me with a doctor?
They have to fill the triage form out in our surgery, so we do encourage that.
Yeah, and
or if they're elderly, fill it out for them. Sorry.
Oh, well done. But if if it's an older patient or a patient who can't fill the form, we can help them. But do we give a patient exactly, ask them the reason for if they come in demanding, I want to see a doctor, I want to see the nurse, do we just automatically give them a doctor's appointment? No. I can see from what you're answering in the chat that no, we don't just give an appointment, because remember, one of the things I found when I worked in urgent care, patients would often come in and say, I want antibiotics. I've got a cold and I know what the symptoms are like. And last time I had it, I got antibiotics. I want one now. I don't give it to them because they asked it. We have to assess the situation. Is there a policy in place where they have to fill out a form where it gets assessed by the clinician? Or they have to, in your case, we have e-consults and someone can call and discuss. One of the things you need to be careful and say to the patient, you're not going to get to see a doctor because you've asked one. You're going to be seen by the most appropriate clinician that's available. And that might be a nurse or a pharmacist or someone else. Never promise that it's going to be a doctor, because if a doctor doesn't call, they're going to get upset. So make them aware, actually, you know what? We have nurses and pharmacists, and we have all these other people that can see you as well. So, can you tell us a little bit more about your symptoms? But what if the patient is actually sounding quite breathless and distressed? I mean, we know that if the patient is unwell, you're going to call a clinician anyway. So you're not going to be messing around with that. If you ever think there's a risk of harm, okay, like domestic abuse concern. Whenever there's a safeguarding issue, the principle is that public safety comes first. Did you know that? So in the sense that it's what is best for the general public good. So you remember in COVID when we had this complete lockdown, and to individuals themselves, it was not in their best interest sometimes to be in lockdown. It affected their mental health. It means they couldn't get to services. But the general public good was for the lockdown to occur, or to have this sort of people being separated and to reduce the spread of the disease. So public interest will take precedence. So if ever there's a situation where there's possible harm to you or to others, we have a duty to inform and to escalate. If we think, especially if it's a child, older person, it can be any age. If there's anything safeguarding, we have a duty to report. We don't really want to be calling the police for everyone, but we may get the safeguarding team to contact the patient. It might be a case where you think there's domestic abuse, so you make the patient a blood pressure check, or you speak to the clinician, and as clinicians sometimes we'll make an appointment for like just a simple review to get the patient away from the abuser to come in, and then we get the safeguarding team involved. Okay. In this case study, what would you do? Other comments? I see a few comments. Offer a GP appointment as an emergency, as an urgency. Yeah. Margaret, you can answer.
Sorry, it's by mistake. 1 second.
Okay.
One cause of poor practice. I need an appointment. She sounds quite hesitant.
And keeps pausing.
Yeah.
So what are you going to do for this patient? She calls and she's very hesitant. She's very quiet, and you can hear a male voice in the background which sounds very aggressive. And she's saying, "It's nothing really. I just want to be seen." Would you? And you're a little bit concerned.
Yeah, it can be mental related issue which can be booked same day with the duty doctor.
Yeah, well done. Yeah, so you assess the situation on the day emergency, raise concerns to the safeguarding lead. So you want to get this person in. If you're even slightly, sometimes you may book someone inappropriately, or it might be the wrong call, but that's fine. It's rather that as long as you don't miss, because the one time you miss something and something happens to someone, So whenever you're concerned, you escalate to the clinician and to the safeguarding lead. Sit down in discussions. We used to have these meetings where we sat down with the safeguarding team, or we used to have our teams, whether it was for the asthma, for the diabetes, for safeguarding, always had an admin staff. Because I used to think it's really important to have an admin staff within the team, because quite often you are at the forefront, you see patients first, you're signposting them to go to different places. So you can give us advice on, actually, we should do this better, we should do that better, we should improve our forms in this way. This is the things that you encounter. And when you're in these meetings, speak up, get heard, because your voice is really important to keeping our patients safe and what we do next. So think about what made the situation concerning, what could go wrong if we ignore things, and how can we make things safe for patients? So what can we do? How can we change our practices to make it safer for our patients? This is a safeguarding flowchart from NHS guidance showing, what to do. So download this, put it on your desktop that you can use it in practice, and we'll come to this thing. So before you make any decision, you need to think, is this very serious? Am I not quite sure what to do here? Because if you're not sure, that is fine. Get advice. Can you ask another of your colleagues for advice? Can you speak to the admin manager, the practice manager? Do you need to speak to the duty doctor that's on? Do not be scared to ask for help. I, as a clinician, there are times when I think, I don't know this, I'm not quite sure, and I will go and ask somebody else. I'm not shy to ask, because I think I would rather ask than something happens and something happens to a patient or something happens to a colleague. So ask, and don't be shy. Don't be scared to ask, okay? So remember always, there's lots of issues, and we've covered all of this. Language barriers, older, frailer patients, people with learning disabilities, mental health problems. And the rule is, if you are not sure, you escalate. Okay, remember poor communication. So I'm just going to sort of read through the next few slides. It's really important, because this is where we miss things. And, if you're not sure what the information is, can we ask more questions? Okay. Can we escalate it to somebody else? Be very open. Can you tell me what's happening? How are you feeling today? And, some of the more close questions. Do you have pain? And remember, most importantly, that we're asking these questions because we want to signpost them, not because we want to diagnose. I've had incidents where I've heard people say, oh, well, just go do this or that. It is not your job to do that. There are some things it's not my job to do, so I don't do it. I don't have the experience to give advice on certain things, so I don't. And you need to also look. I remember when I first, sometimes I may have knowledge on a subject, but am I working within the remit of my role? So we've had incidents where maybe you're an overseas doctor and you've come to the country, and while you're waiting to write your PLAB exams, example, you've got lots of knowledge. But that doesn't mean that if you're working in an admin role, you can start using that knowledge. You can use that knowledge to signpost patients, identify the most appropriate person for them to go, which is great. But you can't start seeing and treating patients. Because if you're not working within the remit of the role, then, you could be in breach of your duty within that role. So just be a bit careful about starting to give prescriptions, advising, oh, well, my mother used to take such and such medication. You should go to the pharmacy and get this. If you're giving advice, then are you practicing as a doctor? If something goes wrong with that patient, are you in court going to stand and say, actually, I have the same qualifications of a doctor. I felt confident to give this. And if you're not actually in the role of a doctor, you could be in a lot of trouble. When a patient's talking, listen. We don't do that enough. We are in a hurry, like one of you mentioned. It's very busy. We are rushing through all the patients. We're trying to get patients allocated as quickly as possible. We don't have time to spend 30, 40 minutes on a call, but always give patients at least the minimum 2 minutes where they can talk and tell us things. And then I say, then you can direct the call to actually say, okay, you've said this, and then you get a bit more information. And remember, always think about confidentiality and protecting their data. Think about how you sound to patients. You might be flustered, you might be busy, 2 receptionists have called in sick today, you're the only one at the desk, you're answering the phone, you're checking on the documents, you're looking at you're trying to send all the e-consults to the doctor, you're answering the front desk, everybody is asking you for things, the nurses are asking for things, patients are coming and screaming because they want their repeat prescriptions. So just be careful that because you're rushed, escalate it. Can the admin manager come down and help you? Can the practice manager? Does the other staff in the surgery know that you are actually, this is what's going on with you? But what you don't want to do is start shouting at the patients. And you've done some of the other sessions where our lecturers have told you is that sometimes you need to just stop and say, I'm going to count to 10 and take a deep breath. And you just have to do it sometimes because it can be very busy and very frustrating. And I have a full list of patients and they've got 10-minute appointments. I'm running over and the reception staff is asking me to come see someone in reception. Somebody else is waiting with a prescription for me. The practice nurse is saying to me, can you come and just check this quickly for me? Because I just want you to look at this wound and write a prescription. And you're thinking, I've got 100 things to do. And sometimes I have to stop, and you need to learn to actually think, what is the most important to do? Who can I get to help me? And you mustn't be scared to ask for help. Always tell patients what to do. So if you are sending patients somewhere, we have this thing called safety netting. And we say to the patients, look, if you're going to the pharmacy first, but if it's not getting better, call us back, call out of hours, when to seek help. Now, this is a role mainly for clinicians, but as a general rule, you can say, look, we're referring you, or I've had a chat to the doctor, or according to our policy, with this, you're saying you've got a bit of a cough, it just started today, you're not breathless, and you'd like someone to look at it. I'm advising you that you can use pharmacy first, but if you do get breathless or start feeling worse, call us back immediately. So you can do that as a thing. We've spoken about all of these. You had a whole lecture about patients being difficult or appearing difficult or getting very frustrated. And this, one of the important things to remember is that we have a no abuse, we do not tolerate abuse from patients or from anyone. Okay. If you ever feel unsafe, you're at the desk or you're on the phone and you're trying to signpost the patient to the most appropriate person, but something happens that makes you feel unsafe, step away from the situation, hand over the situation to somebody else. Get another colleague to take over the phone call or take over the patient. Don't stand there and argue, because do not ever put yourself in an unsafe position. Never put yourself into a position where you could be cornered or patience is very thing is, stay calm. And that's really hard when people are shouting at you. It's like, look, I'm really sorry this has happened. I understand you're quite frustrated. Let me see how I can help you. Don't argue, because when you start arguing, it's just going to escalate. Sometimes when people are arguing with me, I just think, okay, I'm going to step back here. Or I try to steer the argument away. I'm really sorry about this, we mixed up your appointment. Can I tell you what our options are here? I have these appointments. Just get straight to the point. Don't mess around trying to like argue with the person and give reasons for it. And in life in general, sometimes you just need to get to the point and say, okay, this went wrong. What is the solution? Instead of us all sitting here and moaning, you're not going to say that to the patient, but you need to think it in your head. Instead of us arguing about this, let's find a way forward from this. When patients don't want to share, always remember privacy, lack of trust. Are they anxious? When a patient is saying to you, why do you want to ask me more information? And you say, look, I'm not a clinician, but if this helps me to send you to the right place, this is why I'm trying to get more information from you. Okay. And highlight that it's really about you sending them to the right person and not about you trying to gain lots of information, because nobody wants to repeat their information as well. If a patient says to you, I'm not telling you anything, just give me a doctor's appointment, what do? I'm not going to, you don't need to know anything, okay? You just tell me, just give me an appointment. What would you do then? Try to establish why they don't want to talk to you. Would they prefer to speak to another clinician? Is it because they would, you can say things like, is this something private? Would you like to speak somewhere more privately? Try to identify, are they frustrated with the system? Are they anxious? Have they had bad experiences? Is that why they won't give you information? Because you can't navigate anyone anywhere or signpost them to the right person without information. So you need to earn their trust. And that is really important. So you really need to try to gather enough information, but at the same time you cannot force them to tell you information. So get enough information. If you're not sure, you're going to be escalating this. And you can say, look, I completely understand you don't want to talk to me because you're going to talk to the clinician, but I just need a bit more information to make sure that I can get you seen by the right person as quickly as possible. So even a few words just to help me, or just so that when I'm sending it to the clinicians, they have a bit of an idea of what's going wrong. Don't do things like, I can't book you without details. You have to tell me, or be very dismissive and start a conflict. Just try to earn their trust and say, I really, if you could give me some information, would really help me. Patients may not want to disclose. It could be lots of different reasons. Could be a cultural thing. It could be something very private. Could be a thing that they don't recognize how unwell they are. Could be privacy. They don't feel safe to speak because maybe the abuser is next to them. So they just want to see a doctor, but they don't want anyone, the other person. It could be mental health. Could be lots of issues. So always remember, this is not personal. It's not against you. People quite often have their own reasons why they do things. So never take it personally and think, oh, they don't like me. They don't like the look of my face. They don't like me as a person. They just hate all GP staff, the person might be just going through a bad day. So try to earn their trust and try to listen, okay? And think about what's behind the behavior. What is the risk if I don't explore it? And how can I respond safely? So when we're escalating, amber, so we have the very severe cases, the emergency cases we know, got chest pain, they're bleeding, they're very unwell, we're escalating. Then we have the amber cases. And these ones are those ones that could potentially deteriorate. And these are the ones such as fever, abdominal pain, lots of vomiting, mental health. These are the ones you want to really be saying, okay, they need to see a doctor or a nurse the same day. Are there any other ones I've missed? Anything else you think that would be a same day that you know of that I haven't got on here?
Our amber triage says mild, moderate mental health, constipation in adults, fatigue, tiredness with the time, hay fever, skin lesion, recurrent nosebleeds, and palpitations.
Palpitations I can understand, but skin lesions, I guess, depending on the lesion, it's a bit of a hard one, isn't it? Because if you're giving all of those a same-day GP or clinician appointment, you're going to fill up your appointments quite quickly, I think. But if that is the protocol where you work, then you need to follow that. But yeah, okay. And then the green is basically what is low risk. When you're looking at the green, is that these are the ones that you're thinking, okay, could these patients here go to pharmacy first? Is this something that could be seen by a physiotherapist? Someone who's come in a few times, they've had back pain, they've been assessed, there's nothing that indicates that there's something serious going on. Is this something that we could navigate to physio? If it's a medication inquiry, who would you send it to? Oh yeah, can't pass urine, that's more of an emergency. Vomiting, breast lumps or any lumps in the body could be amber. Yeah, because those are the ones you want to really we need to do a 2-week referral on, so they need to be seen fairly quickly. One of the things you need to think is that if us clinicians see them, we are making decisions about, does it need to go to A&E? Does this need immediate immediate antibiotics or painkillers? Does it need immediate assessment? Can this wait? And there's some conditions where they do need to see a specialist, but it doesn't have to be today. So that's the decisions we sometimes have to make. What about who do we send if a patient has questions about a medication? Do they need to see a doctor?
The
They can
clinical
discuss medication
pharmacist.
with a pharmacist.
Yeah, the pharmacist could see them, isn't it? The physician associate. So it doesn't have to go to a doctor for this. Footnotes, who does footnotes in your surgery?
A GP sometimes does them without an appointment, depending on whether they've seen a GP before or not.
And
if
who
it's a
else can-
continuation, he might just do the form.
Yeah, fair enough. And it might be something that it can be done through an e-consult, isn't it? Who else can do footnotes in your surgery?
Physiotherapist.
Physiotherapist, yeah. Who else? You know, nurse practitioners can do sick notes as well, the footnotes. So you need to check, does your nurse practitioner feel comfortable doing it? Because we can write sick notes, footnotes as well. So it's something that if the patient is saying, I haven't been to work all week, I need to be assessed and need a footnote, it's, you know, could I put this into a slot for one of the nurse practitioners maybe? So we talked about this already, R's roles. It's these, you know, reimbursement roles where we're using different healthcare professionals to actually navigate, because basically patients are coming in, and what we are saying now is not everybody needs to go and see a doctor. We have all these other healthcare professionals out there, and what your role is to do is that wherever you work, who are these other healthcare professionals? What do they do? Can they see pregnant people? Can they see children? Your local pharmacy, what are their skills there? I sometimes walk around the pharmacy because if people to see what's on the shelf, so I know it's on the shelf there. What do the different people in our practice, you know, does our pharmacist have other roles like hypertension specialist or respiratory? We used to have a respiratory pharmacist. Anything on respiratory, I would just go to him because he knew it, you know. So, you know, can you put some of your COPD and asthma patients in with him instead? So social prescribing is for individuals and communities to take care of their own health. And, you know, around, what is your experience of social prescribing and what do you all think about it? Have you ever had much experience with it? Oh yeah, I like this. One of you have said, one of our local pharmacies has sent a list of medical conditions they can deal with. So it's quite important, if you don't have that list, is to maybe chat to the pharmacy and say, what do you all see? Can we keep a list in our practice? Because that will help you all quite a lot to think, okay, all of these things we can actually send. And a lot of pharmacists have different levels of skills. Some of them can see pretty much anything. Some have a limited list of what they can see. And, you know, if there is a prescriber, some pharmacies can actually run their own minor illness clinics as well. So like on a Monday morning, when all the appointments have been taken up by 9 o'clock, you know, you want to look at what other options are there for me. So person has a concern, they make an appointment, and we actually, if we believe that we can get them onto the social, you know, we can do social prescribing, we will then refer them to the relevant team members that can take over the care and continue it. And, you know, I think where you guys are, you'll have some really good systems in place already. There's been a lot of work done. There's a lot of systems in place. And if you don't know about it, try to get in, sit in on meetings and find out what's going on around. Because remember, you are that first port of call. So the more knowledge you have about what's going around, because your job is not just answering phones, but it's about making decisions, you know, and you're pretty much the most valuable people in that practice. You know, you may go on to decide to become nurses or pharmacists or managers, whatever you do. Remember that don't underestimate how valuable you are. Somebody once said, oh, I'm just a nurse. And I thought, but nurses do so much of things. How can you say you're just a nurse? So you're never just anybody. You're always important. I always believe we're in roles, they're important, and we have a role to play. So urgent slots are for new problems where the patient is unwell and they're going to probably, when we look at, you know, they're giving us a history or a narrative that says they are very sick. And this is things like children. Remember, children, they can get unwell very quickly, especially when with children, their airway is their problem. It's not developed. So when children come in with respiratory problems, breathing problems, be more inclined to get someone to see them the same day and see them in an earlier appointment. Abdominal pain, that's a little bit harder. And sometimes you think, is this just diarrhea and vomiting because they ate something? Maybe you might just need to speak to a clinician and say, can you give me advice on this? People with a fever, now remember, when you are unwell, your body responds by this big inflammatory response. Your temperature goes up, and that is quite normal. But then if you're not eating, when you're unwell, you don't want to eat anyway. But when people stop peeing, that's for us what we call a red flag. They're vomiting so much they can't keep anything down. They need someone to see them. Either we're going to give them an injection for it or we're going to do something, but we need to assess. People curled over in pain, people saying, patients were saying, I'm taking painkillers, it's not helping. So all of these things for us is what we call red flags, and we'd like to see them quite quickly. Your routine appointments is more things like, oh, I've got a skin mole, can somebody check it for me? I've started having a bit of bleeding, and I'm having diarrhea and constipation. It needs to be seen, but not necessarily today. Breast lump is actually a routine face-to-face. You don't want to give it, the person's very anxious. So while a breast lump, because what you need to remember is when we give appointments, the way we navigate is when we triage patients, we decide, if I send them to hospital today, how urgent is this? Is this something could wait, where we give them an appointment to go to see a specialist? Because if they go into hospital and they have a breast lump, is the dermatologist going to see them today? Whereas giving them an appointment to see a clinician who will do a referral, and the clinician might speak to them on the phone or face-to-face and do a referral, and they get seen by a dermatologist, might be better and less traumatic than sitting in A&E, and then A&E is like, we are so busy, why have you come with your breast lump? Menopausal bleeding, that's something where we worry about cancer. These three, we're worrying about cancer. But it doesn't need an immediate appointment. It just needs someone to see or talk to this person quite quickly and do a referral. Patient says they've been having a cough for a long time, it's not getting better. These are sort of things that actually, we can manage over the phone or we can do routinely. Painless lump, patient is worried, and you need to remember we need to manage people's expectations, but we need to also consider their concerns. If they're very concerned, can we get a clinician to speak to them rather sooner rather than later? If you're ever unsure, speak to the duty doctor or nurse. Okay, patient calls and says, I've got lower back pain for a few days after lifting something. I've got no weakness in my hands or legs and I'm peeing okay. So what should we do for this patient? Do we book them an urgent appointment, send them to physio, call the ambulance, or say, actually, I'm quite busy now, can you call back later? What do you all think?
A routine appointment with a physiotherapist?
Yeah, a routine appointment with physio. If there's nothing to worry about, I mean, if you're ever concerned, if this is like a new back pain, they say something like, I've hurt myself, I've had an accident or I've done something to injure myself, then you think, okay, this could be something more serious. But they're like, I've had this before as well, and I've got painkillers, but I just need something. If you think, okay, this is not really my remit, but a lot of these, at any point, if you think, I don't feel comfortable with this, you refer it. But I'm just going to go through a few scenarios where you could manage this in a way. Lower back pain for a few days, nothing that sounds sinister, you can refer to first contact physio. I've got a cough and sore throat for a few days now. Otherwise, I'm okay, but I've got this cough and it's not going away. I'm not short of breath or have chest pain or anything. So what can we do for this person? Do they need an ambulance?
Pharmacy first.
Pharmacy first. Well done. So this is something pharmacy first could see, because this is sort of within their remit, isn't it? What about this one? This case scenario. I think you can get the crisis team involved here. So do they have a crisis team that they're seeing, or do we need to refer them to the mental health team? Because we do have a few cases of this. They're feeling lonely and struggling. It may not need an urgent thing. Would you say, oh, well, if you're feeling very lonely, you should really speak to someone in your family. Is that the right advice?
They can speak to a social prescriber because they can offer certain
yes,
they're called places they can
support.
go to speak to people.
They can afford
groups and stuff that they can go to and make friends, that sort of thing.
Do you remember I was saying about that 75-year-old lady that she was very lonely, and since her husband had died, she basically hadn't come in to take any of her blood pressure medication, because after her husband died and her friends had already died and only her husband was left, and she had been his primary carer, and after he died, she felt, I have nothing to do in life. My one job was looking after him, and he was my companion. It's gone, and so in her case, we got the social prescribing team. It was a social prescriber referral where, they got age concern involved, got involved in activities, got into the practice. We got her back on her blood pressure medication. So use the social prescribing is something we need to start using more. Don't you think, Nicola?
Yeah, we can refer. I mean, as I say, all of ours go through the triage system with the GP, so we don't always make that decision ourselves. But yeah, 9 times out of 10, the social prescriber is very helpful.
It is, and I think, the age-old thing was that, oh, it's all about mumbly-jumbly kind of thing. I need to see a doctor. But I think we've moved away from this, everything needs to go through a doctor. Healthcare has evolved so dramatically that now we need to be using other resources in helping patients. What about this case? Anybody saying book a GP appointment in 2 weeks?
I would say same day if they're not eating.
They're not eating and they seem well. And remember what I said, children can get unwell very quickly. You want to know how old is this child, and the younger they are. One of the things is this: when a child is up to age one, they get quite a few vaccines. So when they get to age two, they've got a lot of vaccines and their immunity has been boosted. Okay. The problem though is when they get to age two, they go to a nursery where they meet lots of other children. And on average, a child will get about, say, 8 to 10 colds of episodes of fever a year. That is a system trying to, get used to bugs and basically to build up their immunity. So for us as clinicians, we are used to the fact that children will get ill quite often. And they will spike a fever because when you're a child, your brain has not matured enough. And there's an area called the hypothalamus, which regulates your temperature. And that only gets mature when you're about 6. So until that age, children's temperature can fluctuate. So the temperature alone for us is not so much of a big deal. It's very important though. It's other things. They're not peeing, they're not eating, they're not themselves, then we want to see is actually, do we need a clinician to at least phone and take more of a history from them? Because when children get sick, they get sick very quickly. How about this case? We are almost done now. Anybody would recommend a home remedy? Oh, yes, stomach pain. Well, actually, if you have some, I don't know, some leaves, and if you have some green tea, some chamomile tea, it'll make you feel better. Would anyone dare do that? I see some of you have a policy.
Probably sorry. I was going to say on the day appointment.
On the day appointment, it comes under your amber, doesn't it? Stomach pain is more amber, so you want them seen today. Especially with stomach pain, we want to exclude things like appendicitis or very acute abdomen, so you really want a clinician to be looking at them. What about somebody who's saying, I'm really anxious and not coping? They're not suicidal. We have 5 minutes left, so to get through the next few case studies, you'll need to answer quickly.
We can refer to the mental health practitioner.
Yeah. You can refer to mental health. What resources do you all have available and use them? How about this? Would you call this red, amber, or green?
Red.
He needs to be assessed immediately, either by our doctor or he needs to go to hospital. So this is not someone we're going to say, okay, we'll put you in a slot and the doctor will call you later. You need to probably transfer it to a doctor or alert a doctor quickly, or ask the family to call, if they're calling us, is to call an ambulance. Okay. Head is dizzy, I'm not good, and the person doesn't speak English very well. A, B, C, or D? C. Because sometimes we need to just try to get as much information, speak a bit simply, so we can then escalate if we're not sure, but it might be something very simple or something very complicated. Now, if someone's got a headache and dizzy, some of the things we worry about is like a stroke, and normally what are the signs of a stroke? One side of the face drops,
Face drooping,
weakness in the hands and legs, can't speak properly, so if we're seeing that, we know straight away, call an ambulance. But when things like headaches and stuff, we need to be assessing. So you want to try and get as much information as possible. So green is we can refer a signpost. Amber, we need a clinician to see. And red, you want to escalate. If the patient is in the surgery, get a clinician. So even if you decided this person is so unwell, we need an ambulance, you still get one of our duty doctors or one of our clinicians, because if they become, while we're waiting for the ambulance, somebody has gone to print out the patient's records, get the emergency bag, put the patient in a safe place, so maybe in a clinical room, and lying on a sofa so that they don't fall to the floor. Get a clinician in to assess them and be with the patient, because they will stay with the patient until the ambulance arrives. The patient should not be left on their own. When a patient doesn't turn up, so we've given them appointments, but now they don't turn up, what do we do then? What is your system?
The clinician usually calls the patient first.
Yeah. You want to know, why didn't you come? And remember, if it's a child, we don't say DNA, we say was not brought. A two-year-old cannot DNA. They're either being brought to the surgery by a relative or parent, or they're not. And if they're not brought, especially in children, it always alerts us to, why had they not come in? Did mom just forget? Were they in school? Something happened. And you must always think about, is there always safeguarding issues around this? But DNA, why did they not come? What other services do we have? Do we have evening clinics? Do we have weekend clinics? Because people are working, they're working long shifts. Can we actually make them aware that we have all these different types of clinics that they can be coming to as well? If we have clinicians who are maybe proficient in certain languages, can we put them into their appointments? What can we do in terms of supporting them in terms of digital access? If someone has a learning disability, how can we support them and help them? Okay. Creating a vulnerable system. A vulnerable system is really being quite alert. Children under the age of 1, those over the age of 65, cancer patients who are sort of like having palliative treatment, maybe because of arthritis, because end of life care, because of cancer. Remember, cancer is not the only reason you have palliative care. People can become significantly unwell with something like heart failure. Mental illnesses, anybody who's on a vulnerable register. So all of these ones you need to be thinking about, how can we get someone to see them fairly quickly or get them seen? So have a list in your practice with the vulnerable system, okay? Make sure patients understand the system. What are we doing locally to get the patients to understand that they can access us in different formats, but also that we have other services available. We have an STD clinic. We have a contraception clinic. As one of you said, there was different types of clinics that you'll have at your practice. What days are they? Are they alerts going out? Is there we used to have a little flyer that used to go out once a month saying, this is what's happening in the surgery. We have a new nurse, or we have a smoking cessation clinic. So sometimes it saves your job of signposting if you're actually making patients aware of what's available. We always evaluate what we're doing. So looking at feedback and looking at what are people complaining about and what they are saying we do well. Or don't always look at complaints. And complaints can be upsetting. It's like you see a complaint and you think, oh my God, and you feel bad about yourself. But remember, a complaint is an opportunity to learn. So I always look at it, even though I do feel upset because as a person you do, I sometimes think, okay, what could I have done better as a surgery? Because remember, you guys don't work in isolation. What could we do better for patients? And what could we do better for ourselves to make our own jobs easier? Look at patients' feedback and see where are the areas that you need to develop as staff. Lots of different publications looking at, one of the things we have found is training admin staff and effective signposting by admin staff can make our jobs significantly easier. There's a lot of patient safety improvement that has come from this. So, if you guys are not sure, escalate. But if you all do signpost, it does mean we avoid everyone going to hospital unnecessarily. We send them off to the right services so they get the best care possible and in the quickest time possible. Okay, so I don't know why I put this saying. I must go down to the seas again. Let me just read that. To the lonely sea in the sky, and all our arcs is a tall ship and a star to steer her by. Basically, you are steering the ship. You're in charge